We spoke earlier about 11778 men. Now let's talk about the other mutations. Could we talk a little bit about 3460 and things patients would want to know?
Well, certainly Valeria can add much more than I'm going to say because he can grow these cells in a culture. But the bottom line, the simplistic way of looking at it is 3460 is worse, just as 1444 is better. Now, what's interesting is even though there are a few ways that that's true in terms of likelihood for spontaneous recovery, the benefit of adiponone or other things working, and so on, there's still a tremendous amount of similarity in terms of, if you get it, how the disease looks. So we can't make the distinction clinically. If somebody comes to me without a blood test, I won't be able to say which of the three it is. But still, if it's 1444, it's a more optimistic point of view for both getting better by itself or getting better with therapy.
Right. So the three mutations cover 90% of patients. And biochemically speaking, 3460 is worse because lowers the activity of complex 1. And now that complex 1 has been crystallized as a huge, big protein with all these different subunits being assembled, we understand better the mechanism. So 3460 is in the subunit which interacts with the coenzyme Q carrier. The other two mutations, 11778 and 14484, are actually not lowering the activity, but they are reducing the efficiency of conserving the energy. So they're still doing something that produces a defect of complex 1. But just to give you some examples, as I would consider 3460 on one side and the other two on the other side, 3460 has the lowest male to female ratio. It is usually 3:1. And 11778 is 4, 5, 6:1, and 14484 is 8:1. So most of the patients with 14484 are essentially males. It's very rare to see a female with this mutation. The other thing, the two mutations, 11778 and 14484, are associated with a specific background. Significantly, if they are on haplogroup J, this particular background with other variants in complex 1, modifies the severity, not the severity, but the penetrance. So more people could get affected if you have the combination of the two mutations and haplogroup J. 3460 is not associated with haplogroup J, so it's strong enough actually to manifest as a disease even without other particular backgrounds or other factors. So there are many scientific reasons for differentiating these mutations. But I totally agree with Alfredo that when it comes to clinic and what you see in the exam, in the neuro-ophthalmological exam and in the progression, I would say that the disease is always the same. You hit first the small axons, then you get the medium, and eventually, if the situation is very severe, the larger ones. In 6 months, everything is sort of finished, and then you start having the chronic phase. You cannot really distinguish from that point of view. However, 14484 has a clear-cut highest ratio probability of recovering spontaneously. This is happening in particular if the age of onset is less than 20 years of age. So younger is better if you have 14484. Older people, if the disease starts in an older age, the capability to recover is pretty much the same for all three of the mutations. I think I said quite a lot. What about you?
No, essentially, yes. There's not much I need to add here that has not been covered. That the 14484 is really quite different in terms of the much higher rate of spontaneous visual recovery. I guess for 3460, the only thing is, it tends to be a smaller group of patients. And certainly this male to female ratio that you mentioned, there are some studies where there are more females affected, but there are also other studies like the Anita Harding study from the UK where the male to female ratio is more like what you would expect. So I think that's not clear-cut because there's small numbers, these case series, not enough to perhaps make too strong judgments.